In this lesson, we will be covering the treatment of asthma and COPD. The goals of treatment of asthma and COPD are quite similar. Firstly, is to reduce symptoms. These are the symptoms of wheezing, shortness of breath, and decreased exercise tolerance. The other goal of treatment is to reduce the long-term risk. This means to prevent exacerbations, to slow down the disease progression, and to prevent death from the disease. Let's look at the overall management of asthma. Since a large majority of asthma cases are linked to allergy, it is important to identify and avoid allergens where practical. For example, occupational allergens can be avoided and mold can be removed in the home. But treatment has also evolved over time. Instead of avoiding the allergens, another strategy is desensitization. That is, administering extracts of the allergens in precisely calculated doses to induce tolerance. This can be administered through subcutaneous injection, which is into the fats, or sublingually, which is under the tongue. Medications include bronchodilators, which open up the airways, and anti-inflammatory drugs. We will go through each of these drug classes in this lesson. Now let's look at the management of COPD. The most important lifestyle change in COPD is to quit smoking. Other non-pharmacological treatments include pulmonary rehabilitation. This is conducted by a physiotherapist and consists of exercises and education. Oxygen therapy may be required in more severe COPD. Very severe COPD may even require surgery or lung transplantation. The medications used in COPD include bronchodilators and corticosteroids. During COPD exacerbations, which are usually caused by respiratory infections, antibiotics may also be used to treat the infection. These are the drug classes used in asthma and COPD. Beta-2 adrenergic agonists and corticosteroids can be used in both asthma and COPD. Anticholinergic drugs are used more in COPD, but also in asthma. Methoxantins, they used to be quite commonly used, but they are less commonly used now for both asthma and COPD. And there's also leukotriene antagonists, which are used in asthma only. Let's first look at beta-2 adrenergic agonists. Before we start, let's do a quick recap of the sympathetic nervous system, which is responsible for the body's fight or flight response. When the sympathetic nervous system is activated, adrenaline and noradrenaline are released and bind to alpha and beta receptors to bring about their effects. Let's zoom in to beta-2 receptors, which are found in the lungs. Activation of the beta-2 receptors result in bronchodilation, which is useful in the treatment of asthma and COPD. So, beta-2 adrenergic agonists work by binding to and activating the beta-2 receptors in the lungs. This leads to a relaxation of the smooth muscles surrounding the walls of the airways, resulting in bronchodilation. Just a note here, beta receptors are also found on the heart and skeletal muscle, and activation of these receptors would lead to the side effects of these drugs. There are two types of beta-2 agonists available, short-acting beta-2 agonists or SABA, and long-acting beta-2 agonists or LABA. I'm sure many of you have seen asthma patients carrying around this blue inhaler. This is salbutamol, which is used to relieve the symptoms of an acute asthma attack. As we have seen earlier, the natural agonist of the beta-2 receptors is adrenaline, a hormone which is secreted by the adrenal glands. Adrenaline is used as an emergency medication in the treatment of anaphylaxis, which is a severe, life-threatening allergic reaction. But it is not used for the treatment of asthma. To find out why, let's compare adrenaline and salbutamol. Adrenaline is a non-selective adrenergic agonist, and it binds to both the beta-1 and beta-2 receptors. On the other hand, salbutamol is a selective beta-2 adrenergic agonist. Because of its non-selectivity, adrenaline can cause side effects such as increasing the heart rate, causing tachycardia, that's rapid heartbeat, and cardiac arrhythmias, which is irregular heartbeat. On the other hand, salbutamol produces little or no cardiac stimulation and few systemic drug effects, that is, if it is taken in therapeutic doses. The duration of action of adrenaline is very short, approximately 1 hour, whereas for salbutamol, it can last for at least 4 to 6 hours. As we have seen earlier, salbutamol is a short-acting beta agonist. Another example is terbutaline. SABAs have a rapid onset of action, that is about 15 minutes, and a short duration of action in 2 to 6 hours. Because of their rapid effect, SABAs are used as quick relievers during an asthma attack or COPD exacerbation. They can come in the form of inhalers. So this is Ventolin, which is available as a metered dose inhaler. This is Procanol, which is available as a dry powder inhaler. Nebulizers are machines which convert the liquid medication to a mist to be inhaled. Nebulizers may be preferred in emergency situations when rapid relief is needed, or patients who have difficulty coordinating the use of a metered dose inhaler. Besides inhalation, SABAs can also be given orally. When beta-adrenergic agonists bind to receptors outside of the lungs, they may cause side effects such as tachycardia, which is fast heart rate, arrhythmias, which is irregular heartbeat, hypertension, palpitations and tremors, hyperglycemia, and hypokalemia. However, these side effects are greatly reduced when the drug is given by the inhaled route, since very little drug enters the systemic circulation. Besides short-acting beta agonists, there are also long-acting beta agonists. Examples of long-acting beta agonists or LABAs are salmeterol and formoterol. These are long-acting bronchodilators which keep the airways open for a longer period of time. LABAs have a slower onset and longer duration of action. Therefore, they are not used for quick relief, but are used as preventers to prevent exacerbations. Next, let's take a look at corticosteroids. Corticosteroids suppress the inflammatory response of the immune system, and the mechanism of action is actually very complex, involving anti-inflammatory mediators such as histamines, cytokines, and leukotrienes, as well as cells such as mast cells, eosinophils, and macrophages. In this module, we will not be covering the very complex mechanism of action of corticosteroids. Corticosteroids can be given either as inhaled form, that is ICS, which stands for inhaled corticosteroids, or in oral form. Examples of corticosteroids include beclomethasone, budesonide, and fluticasone, which are given as inhalers. Prednisolone is given orally. Corticosteroids can cause a wide range of side effects if they are taken systemically. These include suppression of the immune system, hyperglycemia, which worsens diabetes. The skin becomes fragile and bruises very easily. Osteoporosis and reduced bone density. Weight gain because of increased fat deposition as well as stimulation of the appetite. Failure of growth in children and delay of puberty. Adrenal insufficiency, this is if the steroids are used for a long time and stop suddenly. And glaucoma and cataracts. Inhaled corticosteroids are delivered directly to the lungs, so very little drug enters the circulation, resulting in fewer systemic side effects. However, during inhalation, the drug may be deposited in the mouth or throat and may cause oropharyngeal candidiasis, also known as oral thrush, which is a fungal infection. Some patients may also experience hoarseness or loss of voice. To reduce the occurrence of these side effects, Patients should always gargle and rinse their mouth after using a steroid inhaler. They can also opt to use a spacer to decrease the deposition of drugs in the mouth. These pictures show how a spacer looks like. The metered dose inhaler is inserted into one end, and the other end may have a mouthpiece or a face mask for inhalation. Our next drug class is anticholinergic drugs, which block the action of acetylcholine. Let's do a quick recap. What is acetylcholine? It is a neurotransmitter, and it acts on two classes of receptors. Nicotinic receptors are found in the skeletal muscles, in nerve ganglia, and in the central nervous system. Muscarinic receptors are found throughout the CNS and the peripheral parasympathetic nervous system. So the parasympathetic nervous system controls the rest and digest response in the body. When the parasympathetic nervous system is activated, it constricts the pupils, stimulates flow of saliva, constricts bronchi, slows down the heartbeat, stimulates peristalsis and secretion in the intestines, stimulates bowel release, and contracts the bladder. So since the parasympathetic nervous system causes bronchoconstriction, we want to block its action in order to cause bronchodilation. So anticholinergic drugs work by competing with acetylcholine for the muscarinic receptor. By blocking the muscarinic receptor, it prevents bronchoconstriction and mucus production, which are caused by acetylcholine. Anticholinergic drugs are more commonly used in COPD compared to in asthma. There are two types available. There are short-acting muscarinic antagonists or SAMA and long-acting muscarinic antagonists or LAMA. An example of a short-acting muscarinic antagonist is ipratropium bromide, which comes in the brand Atrovent. This is a reliever medication. Compared to salbutamol, it has a slower onset of action, but the effect lasts for a longer time. Inhaled anticholinergics are very poorly absorbed, and therefore they cause very few systemic side effects. So the main side effect would be dry mouth, but it may cause anticholinergic side effects, for example, dry mouth and throat, sedation, increased heart rate and palpitations if the medication is swallowed, or if it is accidentally sprayed into the eyes, it can cause dilation of the pupils. For long-acting muscarinic antagonists, an example is tiotropium bromide, brand name Spiriva. LAMAs are not used as relievers, but they are used to prevent exacerbations. Another class of medications are methyl-xanthines. Methyl-xanthines are a group of naturally occurring substances that are found in coffee, tea, chocolate, and related foodstuffs. An example is theophylline. It works by competitively inhibiting phosphodiesterase enzymes, which are responsible for breaking down cyclic AMP in smooth muscle cells, and this possibly results in bronchodilation. Theophylline also binds to the adenosine receptor and blocks adenosine-mediated bronchoconstriction. Theophylline is taken orally, and the side effects are quite similar to caffeine. So it can cause nausea, vomiting, anorexia, which is loss of appetite, palpitation, tremors, and insomnia. So a word of caution here, theophylline has a narrow therapeutic index, and overdose of theophylline can potentially cause fatal arrhythmias. It also interacts with many drugs as it is highly metabolized by the CYP450 enzymes. So because of this high risk of side effects, nowadays theophylline is very seldom used. The last class of medications that we would cover is the leukotriene antagonists. So what are leukotrienes? Leukotrienes are inflammatory mediators. In asthma, they are produced in the body in response to inhaled antigens, causing mucus production, bronchial constriction, and inflammation. So leukotriene antagonists would either block the action of leukotriene receptors, for example, montelukast and zafirlukast would do this, or they can block the production of leukotriene, and xylutone does this. These are oral medications, and montelukast or brand name Singulair is the most well-known one. Leukotriene antagonists can cause side effects. So montelukast and zafirlukast can cause headache, nausea, and diarrhea. They can also raise the liver enzymes. They are also associated with a rare adverse drug reaction called Churg-Strauss syndrome, which is associated with vasculitis or inflammation of the blood vessels. There is also a box warning by FDA for montelukast. A box warning is also known as black box warning, and this is the strictest safety warning that is issued by the FDA for prescription drugs. So montelukast has a risk of causing neuropsychiatric effects such as behavioral changes, depression, and suicidality. So before prescribing montelukast, the physician would need to evaluate whether the benefit really outweighs the risk. So after looking at all the different drug classes, let's look at their overall role in asthma treatment. There are relievers. So these are medications that treat the acute asthma attack, and they are taken when necessary. So relievers would be short-acting beta agonists and short-acting muscarinic antagonists. And then there are also preventers. These are medications that would reduce the frequency of asthma attacks, and they are taken daily. So such medications would be inhaled corticosteroids, long-acting beta agonists, long-acting muscarinic antagonists, methoxantins, and leukotriene antagonists. In the treatment of asthma and COPD, medications are often given in combination, and so the products can also come in combinations. For example, Symbicort is a dry powder inhaler, and it contains budesonide, which is an inhaled corticosteroid, as well as formoterol, which is a long-acting beta agonist. Seretide contains salmeterol, which is a long-acting beta agonist, and fluticasone, which is an inhaled corticosteroid. Then Combivent contains ipratropium bromide, which is a short-acting muscarinic antagonist, as well as salbutamol, which is a short-acting beta agonist. There are actually many types of inhaler devices, and this table is just for your information so that you can look at the different devices available. So in this lesson, we have covered the non-pharmacological management of both asthma and COPD, as well as the drugs that are commonly used to treat these two conditions. There are relievers versus preventers, so please know what is the role of each type of medication. And some inhalers are also given in combinations. So if you are given a combination and you're given the name of the drug, you should be able to recognize which drug class it is from and what it is supposed to do.